Dan, thank you for being here. Dan Chapman is a research associate at University of Oregon Center for Science Communication Research. He is an expert in environmental social science and in risk-related decision-making. And one of the ways in which Dr. Chapman uses his expertise in communication and disaster resilience is to improve public health communication related to risks of wildfire smoke in the Pacific Northwest. So we are all delighted that you are here today to talk with us about this work. Thank you.
So thank you everybody for coming. The title of my talk is Public Perceptions and Actions Related to Wildfire and Prescribed Fire Smoke, Results from Recent Surveys in the Pacific Northwest. This is the first longer talk I've done. I was saying this beforehand to some people that I'm trying to put together a couple different studies into a program of research. They've been published sort of separately, and some are still under review. So this is the first time I'm talking about it in detail. Forgive me for any nerves or if I slip up. Feel free to ask any clarifying questions at the end. So as was mentioned, my name is Dan Chapman. I'm a research associate in the Center for Science Communication Research at the University of Oregon. I've been working there for just under 3 years, and in that time, my work has broadly focused on decision-making about environmental conservation issues and how they intersect with public health. This involves using theory and methods from across the social sciences, and I don't think I have to tell anyone in this room that environmental and public health issues are intimately intertwined and interconnected. And so this interconnectivity has led to great collaborations the past few years, including some folks here at the College of Health, including Perry Heistad, who isn't here today. I was hoping to say hi to him. There have been great collaborations I'm going to talk about a little bit here. So today I'm going to talk about research that we've been doing on wildfire and prescribed fire smoke perceptions. More findings have become available since the initial description that I put out of this talk. So I'm calling a little bit of an audible, switching things up a little bit and adding in some new detail that I was still frantically adding in last night. And as I mentioned, some of these have been published before. I'm happy to share the papers and share any more information with anyone that's interested. But before I begin, I want to tell you a little bit about me. So I identify as an interdisciplinary environmental social scientist, which is just a long way of saying I study human behavior about environmental issues. I consider myself interdisciplinary because my background training is in a variety of different disciplines in psychology, political science, and communications that has intersected at many times with public health. But I try to basically integrate these different ideas together and find commonalities to then produce applied research on issues such as wildfire smoke, fisheries management, and other types of forestry management. So before I came to the University of Oregon, I got my PhD in the psychology of peace and violence at UMass Amherst, where I was studying the links between climate change and intergroup conflict. That was really depressing. So I switched a little bit, and when I was at Yale Law School and the University of Pennsylvania, I worked on climate change public opinion more generally, looking at people's attitudes about the connections between climate change and health, looking at climate anxiety among youth in America and Europe, and a variety of other things, still very depressing. So I then became the research director for a small consultancy out of Los Angeles, where we were working on essentially on environmental conservation issues related to climate change, and then on Medicaid uptake enrollment. So we were using behavioral science principles in ways to bolster Medicaid enrollment in the southern United States. Less depressing, but I wasn't quite in my niche. And so I decided I wanted to study more forestry-related topics, and then in particular, smoke. And one of the reasons I wouldn't be a good science communicator if I wouldn't tie some of the work I'm doing to myself and what I personally feel and am interested in. And so the primary reason I started studying smoke was because I wanted to move out west, but smoke and fire scare me so bad. So I'm originally mostly from the East Coast, and the Northeast, where there's histories of fire, but recently fire is not a dominant force in the landscape. But I saw from a distance the 2020 fire season and had to start weighing, is this something I really want to do? Is this something I really want to go? And then I recognized that this really is an opportunity to merge a variety of things like fire ecology that I was getting really interested in and just poring over books about, and merge some of that interest with my background in environmental psychology and behavioral science. And on top of this, I think this is especially important to emphasize in our current climate, that smoke affects everyone, but it disproportionately impacts people in disadvantaged communities and people that are less well off. And so I think it's important to always hit on this environmental justice angle, even if in the current climate we're encouraged not to. So there's also good research reasons why to study smoke. We know from a lot of different studies that wildfire smoke impacts on communities in the Pacific Northwest are increasing for a variety of factors, climate change being a very prominent factor, but other things as well, such as our current forest management practices and our tendency to sprawl out population-wise into the wildland-urban interface. Now, on top of this, we know that smoke from wildfires pose significant physical and mental health risks. And I have underlined here, this is especially true for children. There is a lot of research coming out on the effects of wildfire smoke, particularly on children and on their respiratory health, and then also those with other existing adverse health conditions. So it seems like pretty much every day a new article comes out talking about hospital admissions related to wildfire smoke among children, things like that. So there's a lot of work coming out in this space. And in spite of this very good public health work, on the side of psychology and communications, the study of perceptions of smoke and actions is actually quite lagging behind our understanding of the public health impacts. So we're getting a pretty good sense of the public health impacts, but we're suffering a little bit in terms of how to communicate effectively about those impacts and how to understand where people are. So with that very general backdrop, I want to talk about a couple different questions for today. The first question is how air quality infographics influence protection motivation among parents. And so what I mean by this is, when you go on your phone or you go online and you see an air quality indication, you see an AQI, it might say it's 50, and it might have a little message about what you should do about it. Sometimes it doesn't. The question is that we had was, are different ways of representing that same information more or less understandable to people and more or less motivating of protection actions? And these protection actions are things like keeping your children indoors or canceling activities that schools haven't canceled that really they probably shouldn't be going to, for example. So I'm going to cover that first topic with a survey experiment that we ran I'm saying the Pacific Northwest broadly, but I'm also including California and British Columbia in there. So forgive me for not being fully correct on that. The second question is a little bit more broad, which is that we want to know how objective and perceived smoke exposures influence actions taken. So thinking about this from a research perspective, we can study how people think they're perceived to smoke and how much risk they think they have from smoke. There's also objective data that says you live in an area, you've gotten this much smoke. And so one of the things we're interested in is essentially, is there a correlation between people's subjective judgments of I was exposed to smoke and the objective data on the ground? And then jointly, do one of those factors more strongly predict the actions people say that they've taken? So basically, is there a stronger relationship between the objective data and what people say they do, and their subjective ratings of their risk and what people say they do? And then finally, shifting gears. So these first two questions come from two different components of a single study that was fielded with generous funding from OSU Aspire. This third question is more recent. What I was throwing in is that the first two questions focus on how to deal with wildfire smoke. This third question is more about how we deal with adaptations to deal with wildfire smoke. So one adaptation, which I'll talk a bit about, is prescribed fire, which helps reduce catastrophic wildfire risk. However, prescribed fire still produce smoke. So smoke is still there. It's still a risk. So how do we understand people's concerns about the smoke, and then how do we message toward those concerns? And so the data from this study come from a field survey in Bend that we did. Oh my gosh, it was last spring now. Time flies. So the first study is on this infographic experiment. So very quickly, as I was mentioning, there's multiple ways of visualizing wildfire smoke risks in terms of the air quality and parentheses health index. So what we mean here too, actually I'll get to this in a second, but we say that research hasn't tested the efficacy of different visuals, meaning different ways of representing this information just has not been examined in the literature. We are also curious if the scale of the air quality information influences how much risk people perceive. The US AQI uses a scale from 0 to 500 plus. The Canadian Air Quality Health Index, which is very similar, calculated slightly differently, but it's roughly similar. It uses a 1 to 11 plus scale. So there's these two indices meant to represent essentially the same thing, and they're on very different scales. So we're curious, does one of these scales work better than another? One of the things that I thought might happen from the psychological literature is that the smaller scale might actually better convey the magnitude of risk than the larger scale. Because if you think there's some work showing, for example, that if you give people, if you say there's a 200 out of 400 versus a 1 and 2, the 1 and 2 sounds worse to people, even if it ultimately ends up being the same numbers. We also were curious about the risk scenario and whether different visuals work equally in a moderate versus high risk. And I'll show you a little bit more about what I mean by that in a second. And then finally and critically, we are curious what approach facilitates the greatest action intentions in moderate risk scenarios. The reason being is that in a low risk scenario, the decision process is relatively unambiguous. It's a great day to be outdoors. You don't have to do anything. When it's a high risk, you see a gauge or a chart that's like maxed out on the red. You might not know exactly what to do, but you know you should probably do something. When you're in this moderate scenario, the AQI will often say things like basically unhealthy for sensitive groups. Who is in that sensitive group? The definitions aren't usually made abundantly clear when you're looking at it. It's buried in the documentation that nobody's looking at. But also, are children incorporated into what's considered a moderate risk, and to what's considered a sensitive group? So we are curious, particularly in this moderate scenario, if certain visuals or certain scales better attune parents to this, that their children are at risk, even when the air quality says it's moderate. So the participants for this study were also, for the second study that I'll talk about, so this will go over twice. We had 2,100 participants recruited from Pacific Northwest and California. They had to be a parent or a guardian of a child at least 18 years or younger. I just have some of the demographic splits here. And we recruited these participants through two panel providers. And the way, I don't know if everyone's familiar with panel providers, but this is essentially a group of residents that have been recruited via phone calls, online advertising, social media, to participate in a variety of studies. And so they build a panel out of these groups of people. And so we recruited people from that panel. And so it's important to note that because the sample is not truly representative, but it's not truly a convenient sample either, because people were not recruited knowing that they were going into a study about wildfire smoke. They were just recruited to go into a study that we're going to survey. So it's not, we would love to be able to do mail outs and probability dialing for everything. It's very tough and very expensive. And this was about a $20,000 survey. So to situate this sample, just to give you a sense of who these people were off the bat, this is a group of people that clearly were impacted by smoke, believe they're going to be impacted by smoke in the future, and say that they are doing things to deal with the smoke. So this is not a disengaged group. We could reasonably raise questions about whether 77% actually have changed their decisions. But the general point of this is that this is not a sample of people who are opposed to being concerned about wildfire smoke. It's a pretty highly concerned sample. Okay, so this is also a sample that seems to know about the air quality index and the air quality health index, probably because they get it on their phones. So most people said that they have heard of it, that they know where to get information, and they report adhering. Again, whether 76% actually adheres, we don't have the data to validate that, but this is a group that at least says that they're concerned. So for the experiment, did I just lose that? There we go. We had a random assignment where we had participants see either a table, a line, or a gauge visual, which I'll show you examples of in a second. We had two different scales, the 0 to 500 plus scale versus the 1 to 11 scale, and then two different risk levels. And everybody was randomly assigned to a different category. And then to complicate it further, we gave them two different scenarios. First, they were asked about what we called an acute scenario, which is they were basically asked to imagine that the air quality was this level on a school day, and they're making decisions about their children. The chronic scenario, which the use of the term chronic here is not a true public health use of the term chronic. It's more just to differentiate from the short term. We could have said short term and long term. Maybe that would have been better. But this is essentially if it lasted for an entire school week. And this is because we were curious to see if people's decision-making about things like keeping their children home might be affected by whether it's happening for a single day versus an entire week. So in terms of the visuals, this, I apologize, this is a little small, but this is one example of sort of the very vanilla table image where we use color codes from the AQI. We have the index region categories. And then what we did, which isn't part of the actual AQI, but we wanted this to be as informative as possible for the parents in our sample, was we included this guidance for children. And so this basically lays out, based on the research, a little bit more information about what people should consider doing specifically in relation to their children. And I'm emphasizing that we did this because we wanted to give them as much info as possible, but the actual AQI does not contain any of this information. It contains more general descriptions, but not things specific to children. This is the AQHI, which is the 1 to 11 plus in a moderate risk scenario, and then the line chart. So it's the exact same information. It's just represented differently. But everything else, and the scale obviously varies, but we've kept everything else constant here. And then finally, the difficult one is the gauge. This was a fun one to design. We had trouble getting the pies to look the way we wanted them to, but we tried to get the information as consistent across. And so again, the differences here is people saw an arrow pointing to a different spot. And in addition to the arrow, I should have mentioned this, we gave them a really quick description that said, here's an AQI. The number on this day is this, and we bolded it in red and underlined it. So in addition to it being on the chart here, we explicitly said it in the text. And then our primary dependent measure that I'm going to talk about were these action intentions. And I realized I forgot these were asked specifically in reference to doing things for their children. It's not in the top of the question, but we had it in the preamble. So they were asked to consider each of these about thinking about their family, themselves, and their children. So we asked them these 5 different intentions on a 1 to 5 scale. What we did for the analysis was we averaged them together into a single scale. And these alphas are just a measure of reliability from 0 to 1. So higher scores mean more reliable. We did also do analyses separately, looking at each of these items independently. They mirror the overall results. So we talk about them as the average. And what these reliabilities essentially say is people's intentions to do one of these behaviors is very highly correlated with their intentions to do these other behaviors. In the future, one of the things I'd love to get feedback on later, and we could talk about is how could we improve this list for future studies so we get a more diversity of behaviors. So this I will mostly skip, but this is just the note. We ran an analysis of variance on the data. We see some main effects and we see an interaction. I'm going to focus on the interaction because that's mostly what we're interested in here. So to orient you to this figure, on the y-axis, we have these action intentions that on average range from 1 to 5. Higher means higher action intentions. The x-axis is the 2 chart types. So it's the 0 to 500 or the 1 to 11. And then the colors are the risk levels. So what we see with the orange, the high risk, is essentially regardless of the type of graphic they see, and regardless of the scale they see, if it's high risk, they have higher action intentions. It doesn't seem to matter too much what visual we give them or what scale we give them. If it's high, it's high. When it's moderate, it was a little bit more nuanced. So in the table, you can see that the line is essentially flat for the green AQI to AQHI, meaning that people didn't differentiate between these. However, in the line in gauge, we saw that the shorter scale, the 1 to 11 plus scale, actually outperformed the AQI scale. And we say outperformed because our goal ultimately is that these green lines, we want them to be as close to these orange lines as possible, because that is reflecting the importance that people need to be taking extra actions for their children. However, in the chronic scenario, we see the same pattern, but we don't see a significant effect. Why this is the case, we don't know. So I wanted to present some open findings rather than something definitive. And so I'm going to talk through here. Basically, what we think is that we didn't think through the differences between an acute and a chronic setting enough to understand the psychology that goes into how people make decisions in those settings. So one of the things we're hoping to do in future studies is essentially do some pilot data collection to understand what activities would you do on a day-to-day basis for your children. What would you do if it was an entire week? What would you not do if it was an entire week? So not taking their kids out of school, et cetera. We want to do a lot more essentially pilot data collection to understand these different behaviors in acute and chronic settings. And then we want to redo the experiment with a tighter methodology and see if we replicate it. On top of that, we also are planning a study that is hopefully going to be run this spring in New York and New Jersey. The reason we're picking there is so both of these states, but especially New York, they got hit really hard with wildfire or smoke from Canada. So Canadian wildfires these past few years have really hit parts of New York. And New Jersey, some people don't know this. You might know this. New Jersey has a history with wildfire. That has gone back quite a long time. They have what are called the Pine Barrens on the coast. It is an area that burns very regularly. It just doesn't burn to the same catastrophic scale as we see in the American West. But so they have real wildfire smoke problems. So we're curious in these two different states, is people's use of these air quality indices differently? Do they think differently about the activities that they would do? And also, are there just socioeconomic differences between regions which might affect what people are willing to do? So we're working on that. So this first study was looking very generally at infographics, but we also wanted to step back and ask the question of, to what extent do people's perceptions of smoke align with the objective smoke data, absent of any messaging that we give them? And so that's what this second study is about with the same sample. So the first question is whether perceptions of wildfire smoke are associated with objective smoke exposure. This is essentially what I was saying before. Is there a correlation between people's subjective sense that they've been exposed to smoke and the objective smoke data that we have on the region in which they live? Second, jointly, what are the effects of both of these perceived and objective measures on the adoption of smoke protective actions, which I'll define more in a second. Third, do the relationships that we're looking at vary depending on the type of objective smoke measure that we use? So when you think about objective smoke data, there are so many different ways we can parse these data. So for example, we can look at just raw PM2.5 particulate matter 2.5 concentrations. We can also look at the density of smoke in the air on a given day. We can look at the number of consecutive smoke days. We can look at the number of days that exceed a certain AQI. But there's a lot of different ways we could look at this. And so we essentially were curious, are there boundary conditions on effects? Are there certain variables that perform better than others? The short answer is no. But we'll get into that. And then finally, more generally, drawing from past literature that we know about people's concerns about wildfire in general, are certain sociodemographic characteristics predictive of the adoption of smoke protective actions absent of their subjective appraisals of smoke? So this just maps out the whole study really quickly. So we see these are the different objective smoke measures that we looked at independently. We have the total number of smoke days that exceeded a certain PM2.5, the density of smoke, the number of smoke waves, the number of smoke days with AQI above 100, and the average PM2.5. So we looked at all of these. We have these three smoke perception measures, which are from survey data that we collected, which is people's subjective past exposure, whether they think they've been exposed to smoke, their perceived future susceptibility to smoke, whether they think they're going to be affected in the future, and then their concern about that smoke. And then finally, we had a series of demographics, education, income, gender, age, and whether themselves or any of their children have a list of specific health conditions that we listed out, including COPD and other things that we know are associated with wildfire smoke. And then we have these smoke-safe actions. I'm going to actually show this on this because it's a little clearer to see. So we first just asked people whether air quality affected decisions that they made about their children. And then we asked them about more of these specific activities and whether they did that. So one of the things to note here is that we kept during previous wildfire seasons, We kept that general. We didn't say in the last year. We didn't say in the last 2 years. There were a few reasons for that. One, we don't suspect that people can accurately recall on like a yearly basis exactly what they did. So there's some concerns there. That really was the primary concern. The second concern is that we wanted to keep our interval of smoke data pretty broad because we did this study in the spring. So we couldn't ask about that year's smoke exposure because it hadn't happened yet. And so we kept it broad so that we could go back several years and look back from, for example, 2020 to 2023, which I'll show more in a second. Oh, and I should also note that for this first study, we were really conflicted on the behaviors that we included because we wanted to ask things that people could potentially do regardless of income. The trickiest one here is using a portable air purifier because there are economic implications of that. But we didn't ask things, for example, like whether people have replaced their entire HVAC system in their homes and things like that. Is that a good action that if you have the money that you should take? 100%. We wanted to keep this as broad for the whole sample as possible, but that is something that we could improve in the future. So this is just a quick, I wanted to very quickly, this gets a little technical, but note how we got the PM2.5 data. So what I'm going to essentially do is I'm going to focus on the findings for the average PM2.5 variable. The rest of the variables look essentially identical, and they're all in a paper with a huge appendix, and I'm happy to share that, but there's too much to share all at once. So what we did is we took postal code level observations of daily average PM2.5 concentrations from the beginning of 2020 up until the start of survey day. So about a 2.5 year period. And we defined smoke day as any day where there was a smoke plume polygon on NOAA's HMS fire and smoke product. These polygons also allow us to derive the densities of the smoke, which we did as well. We got the PM2.5. So basically we used the HMS fire and smoke product to define a smoke day. And then for those days, we downloaded PM2.5 observations at an hourly level from AirNow, and then we created an average for the day. So at each day in the data set that's a smoke day has an associated score. To control, we also controlled for average PM2.5 on non-smoke days. In our modeling, this is really important, for example, because we have places like Los Angeles in our sample. Los Angeles has a lot of non-wildfire smoke related pollution. So we wanted to be able to disentangle the two. So we also pulled the PM2.5 on days that were not considered smoke days. And then we also, because when you get out into places like Eastern Oregon, the air quality sensors, there's air quality monitors in essentially every postal code. Some places don't have one. And so when you get out into very rural areas, so in most cases, the air quality measure that we have for people is very geographically close to where they live. In Eastern Oregon, that's less likely to be the case because people live further away from monitoring stations, meaning the data are going to be less accurate. So to control for that, we included the distance in the model as well. That I just wanted to note that up front that we thought about that. We also looked at some other ways of modeling distance. It didn't seem to affect the results. So in addition to the objective data, we had several survey predictors. The most obvious one is the perceived subjective smoke exposure, where we asked people in the past several years whether they've been exposed to wildfire smoke that they could see or smell in their communities. 72% said yes. We also had indicators of education, whether they had a relevant health condition, their gender identity, their income, and their age. And the reason we included each of these is because past research on actions taken to deal with wildfire more generally tends to find correlations. So for example, more educated individuals tend to be more likely to take the actions. Women tend to be more likely to take the actions than men, et cetera. So we included those as well just to see if we found kind of similar effects. So moving into the results, this will actually go pretty quickly, but so the first question about whether objective and subjective smoke exposure map onto one another, the answer is yes, and reasonably well. So a 10 microgram change in PM2.5 was associated with a 2.54 unit increase in the odds of reporting smoke exposure. To make that a little bit more concrete, so a 1 here is 10 micrograms. So people's probability of saying yes is about 60%, a little less. When we go up to 30 micrograms, it's over 90%. So we do see quite a large change. We also see that objective and perceived exposure both predict actions taken. This is from a separate set of regression models. So you can see a small positive slope. These are significant in both cases, but it is stronger for the binary, whether the subjective exposure measure, than it is for the continuous objective measure, which I can talk more about here. Finally, this is just a really boring coefficient plot, but essentially the way you can interpret it is the more it goes to the right, the stronger the positive the effect was. So on actions taken. So subjective exposure, whether people said that they had been exposed, was the strongest predictor in our model of actions that people report taking. Second is whether they think they're going to be affected in the future. And third is their worry. These are perhaps unsurprising. But we also see positive effects. People who themselves or their children have health conditions, they are more likely to report taking actions, which is a good sign. More educated individuals also are more likely to take actions. There's a small positive effect of income. And then again, this small positive effect for gender, where women tend to report more actions than men. Okay, so we do see that objective and subjective smoke exposure are strongly associated with one another. This was especially true for the PM 2.5 variable that I showed you, but it was also true for other variables in the model. Also, the strongest I actually just said this. The strongest objective smoke exposure predictor was average PM 2.5. And then we see that several of these demographics have a positive effect on the actions people report taking. Okay, so to conclude with some new things, some new hot off the press data, I want to talk a little bit about prescribed fire. And the transition, the way I view this transition is that we first dealt with how people think about wildfire smoke, but we haven't dealt with how people think about actions that will help potentially reduce smoke, but produce smoke themselves. It's a little convoluted. So we know, this is just a really beautiful, stark visualization, that Oregon has one of the highest wildfire risks in the country. The whole West in general, but Oregon, especially the southern and eastern Oregon, are very vulnerable. We know that they're increasing in intensity, and we know we need forest fuel management practices to limit the degree of catastrophic wildfire and ideally limit some of the smoke. This plot, just very quickly, this is from OSU. I should have noted which center put this together. But basically, long story short, red is worse. Red is more dangerous. And I have circled here Bend, which is this big spot here that is very, very red. And because of this, we need fuel management practices to help deal with this risk. So two of the primary fuel management practices are mechanical thinning and prescribed burning. The pros of mechanical thinning are that it tends to be effective. You can sell the timber for benefit, and it's not really a threat to humans or property. However, financial incentives can promote thinning of old growth forests. So if you're a conservationist like myself, that's a big concern, because they can get more money for old growth trees if they, turn them into timber. Also, forests need fire. Thinning disrupts ecosystems that are adapted to fire. So by doing, sometimes we need fire in order for the ecosystem to function properly. It's also very hard and expensive to do at scale. It sounds great, but if you think about going into the backcountry in Eastern Oregon, how are you going to get the machinery out there? So there's real obstacles to burning with to treatment with mechanical thinning in the places where it's needed most. On the flip side, we have prescribed burning, which is essentially setting small controlled fires to helpfully help adapt the ecosystem and prevent larger catastrophic fires. The pros, again, tends to be effective. It can benefit ecosystems and wildlife. It can also be harmful to wildlife, but it can be beneficial as well. And it's relatively cost effective and scalable, because instead of needing machinery out in the backcountry, you need people. The cons is that, as we were talking about earlier, unpredictable weather and other things going on can cause delays or cancellations. So they may plan burns for 2 years, 3 years in advance and have them not happen because of changes in weather. There also is a risk that can't be ignored of fire escape affecting lives and property. They do their best to manage this, but it is fire. It is unpredictable to some extent. And it produces smoke, but probably most importantly for today, it produces smoke just like wildfires do. And this smoke is harmful for public health. And I've talked with public health officials about this, and they're having a lot of trouble figuring out how to message about this. So just a little bit more background on prescribed burning. It tends to be the preferred fire management method compared to mechanical thinning. It's used across the US. This is a chart from 2018. But you can see one area maybe you might not expect, but the southeastern United States has actually done a ton of prescribed burning. The Pacific Northwest is picking up the pace, but it's still lagging behind other parts of the country. And there are potentially real consequences of this. So on the left, this shows the acres burned per state by wildfires. And on the right, it shows acres burned per state during prescribed burns. So we see areas such as the southeastern US that have more prescribed burns appear to have some fewer acres burned per state by wildfires. This is not a perfect story, but there does appear to be a beneficial impact on a large scale of using more prescribed burns. Very quickly, there are barriers to prescribed burns, mostly legal and institutional ones that I'm not going to talk about, but I listed here just so I acknowledge them. But the legal process is being simplified, so we're going to most likely see more prescribed burning in Pacific Northwest. And there is currently a bill. We'll see what happens with our dysfunctional Congress. But there is a bill aimed at facilitating adoption of prescribed burning across the U.S. It's a bipartisan bill. But important for us is, what about public opinion? So what do people think about prescribed fire? Do they support it? What are they concerned about? So surveys dating back to the 90s have looked at this very generally using small mail-out surveys across the U.S., and they tend to document moderate to high support. However, a few studies have been done in recent years, particularly in the Pacific Northwest. And this is especially important given recent catastrophic wildfire seasons. And I note that no studies have been done in the Bend areas. It's not an area that's been surveyed before. So I'm going to move through this a little bit quickly, just with an eye on time. So we set up a project in collaboration with a whole bunch of people, which I'll note in a second, where the USDA Forest Service was planning prescribed burns for the Bend area in spring 2024. And we set up a project where we obviously worked on planning the burns. We disseminated purple air monitors to track indoor and outdoor air quality, did a survey, which I'm going to talk about in a moment. And then we have a process of an act-for-action review to evaluate successes and shortcomings of the process. So there were a lot of cooks in the kitchen on this project. We had several government agencies, both state and local, federal and local. But had a nonprofit group that did a lot for us. And then we had researchers here at OSU, myself at U of O, and then some folks at OIT as well. So very generally, we had a couple questions that we were curious about with Bend residents, which is how familiar they are with prescribed burning, to what extent they support the use of the burning, and to what extent they report various concerns about it, and whether they've experienced smoke during the burns. Sampling, I'll go over this very quickly. Essentially, we had about 1,500 people that we recruited. We worked with OSU's Survey Research Center to mail out 4,000 postcards to random households in the Bend area. We got, after data cleaning, we had 508 back, which might sound small, but it's actually pretty darn great for these days with these kind of mail-out surveys. And then we also did a digital survey that was more of a convenience recruitment on various websites. And we got about almost 1,000 people to participate that way. And so we compare and contrast the data across the different methods. So this just to give you an indication of the sample. So it was a bit older on average, 42%. That was 55 to 75, 10% to 75 or older. Relatively balanced on gender, overwhelmingly white, which is a problem for us. Most were homeowners, and most were relatively well off economically. So this just shows a bit of a distribution of where people were. So most of the people were in Bend proper, but we had some folks out on the peripheries of the Bend area. And then I'm just noting this. So we haven't done these analyses yet, but what I want to do, and maybe you'll have thoughts and ideas for this, is we're going to analyze and compare the data. So this gives us indications of vulnerable groups that are in these households. We want to analyze our survey data and compare and contrast differences based on different vulnerabilities. We just haven't had a chance to do that yet. And I will note some demographic differences in the samples. So the mail-in survey participants were slightly older. They skewed male and they had slightly smaller household sizes. The digital sample had more people that had respiratory diseases or asthma. So there were some differences there. But I'm going to go really quickly through some of these just top-line findings so we can wrap up. 80% of the sample said they were very familiar with prescribed burning. So this is a group that has most likely received mail-outs. They received notices that the prescribed burns are going to happen. So this is not unsurprising that we would see a high proportion, although it was higher than I expected. When we think about whether people think it should be used, and we asked them this after we gave them a brief description about how prescribed fire is used in the area, 79% said that they think it should be used frequently or sometimes. Which seems again very high, but matches what we've seen in previous surveys on prescribed fire. This was another way of sort of asking the same question, which is more about suitability. About 40% said it was suitable only in specific areas. 6% said it wasn't suitable anywhere in the county. When it comes to concerns, the two top concerns were concerns about smoke and the health impacts. So this is different from past studies. Past studies that have been done on prescribed burning tends to find concerns about smoke to be somewhere in the middle of this list. And in Bend, we see it as the highest. So that's something important to note. People are quite concerned about the smoke, and I don't have the correlation shown here, but there is a correlation of about 0.45 between concerns about smoke and support for prescribed burning. So the more concerned they are, the less supportive they were of the practice. So we do see high levels of support, but for the people that are attuned and worried about smoke, they do have hesitations about the practice, suggesting that there's important messaging that needs to be done. I'm going to skip over this one. And another thing I just want to note is that this group was exposed to smoke in the spring of 2024, presumably from the prescribed burns. So people are noticing smoke, and it does have an impact on the communities. In terms of actions taken, and this is just about the end here, I wanted to just note for you, we asked about a whole different types of actions people said that they took when they encountered smoke this spring specifically. Most people took the lowest cost actions, shutting doors and windows, staying indoors, checking air quality, things like that. Far fewer people used, for example, respirator masks. Only about 8% said they used that. 11% said they did nothing. And smaller percentages said they did things like making sure they had adequate medication on hand, which is something that is encouraged in pretty much all of the messaging about wildfire smoke. Okay, so Bend area support for prescribed fire is pretty high, but there are concerns, and these concerns about smoke are higher than we've seen in other studies. This might suggest a tide shift in the work. People prefer low-cost actions. And while they're supportive of prescribed fire, this really underscores that communications need to address concerns about smoke and provide actionable steps that people can take to reduce their exposure. So putting it all together, instead of providing you with a bunch of definitive answers on past work, I wanted to show you a bunch of firsts. So to our knowledge, this was the first study on infographics of this kind, let alone in the Pacific Northwest. It is the first investigation of subjective and objective exposures in the Pacific Northwest. To our knowledge, there's only one other paper published that has done this anywhere in the world. So this is only the second time. And it's the first survey in Bend on burning and smoke concerns. And that is a targeted area for future prescribed burns. So it's a really important area and it's an area that's still growing. But we have many questions left unanswered that I'm hoping we're going to do more research on, and then hoping I can get some feedback from y'all. So which infographics are best? We don't know. I deliberately presented the evidence that we have as up in the air, because we found a signal that matched the hypothesis that we had, but we need to replicate it, and we're not sure why it didn't show up in the other scenario. So we need to do more work there, and hopefully others will also pick up and do more work on how to portray smoke through infographics. There's also this question of, so if we know that these subjective experiences that people have in their day-to-day life is actually quite predictive of the actions they take, the question for communicators is how can you leverage that sort of psychological experience, that personal experience of smoke, to not terrify people, but to motivate people to take action? This is an open question. I have some ideas, but I don't have the answer on how we can do this. And then finally, this question that I've been talking about with public health folks in Oregon is, how do we balance the presentation of the benefits of burns with a careful highlighting of the drawbacks and highlighting the actions that people can take to deal with the risks that they might be exposed to? So we're hoping to have more answers soon. So that was just the start. And as I close, I want to really thank everyone who made this work possible. Kathy Slavic in particular is a collaborator of mine at the University of Oregon. None of this would have been done without her. I owe her so much for this work. Ellen Peters as well. Holly, Michael, Perry here, Stephanie, Lee, and Jacob. I also want to thank Aspire for funding the first part of the work, and the National Science Foundation for funding some of the other work. And thank you for listening. Hope we have time for that. Yeah.
About 10 minutes for questions. And if you can repeat the questions if you go down.
Okay, you mentioned at the very beginning that the most impacted people are disadvantaged. Well, your first study on infographics didn't seem to touch that population at all.
Yes.
They had highly educated, with high income families. Are you going to replicate it?
Yes. So the question was essentially, I raised the importance of disadvantaged communities being impacted, but our studies do not adequately tackle those populations. And yes, that is a complete shortcoming of this work. Our hope, so I would note a few things. One of the biggest obstacles that we come up against is recruiting those individuals into these studies. Especially, I've had more trouble. I've worked in a variety of parts of the U.S. I've had more trouble in Oregon and Washington than anywhere else that I've worked in the U.S. And in particular, recruiting, for example, the Hispanic population. So we are hoping the materials we put out are in English and Spanish. We are hoping that in our follow-up studies we can tackle this. One thing we did do, which is not completely satisfactory, is we explored whether, for example, the infographic experimental effects look different for the less educated in our sample versus the more educated, and look different for low-income groups in the sample versus upper income. We didn't see those differences, but I'm not confident to say that they don't exist. I just will say that we didn't see them in that particular study. So yes, we're hoping to address this in the future. And we're hoping, I hate to lean on money, but we're hoping we have the funding to recruit lower income, because it requires substantially more time and money. Yeah, it's a great question though. Thank you. Yes.
And thanks. This was fun to see it all come together. With regards to your third study with prescribed burns, my understanding is those do tend to be shorter duration events. So are you kind of looking at, I loved how you used the word like smoke waves. Mm-hmm. And I think that should probably be used more often. But did you take into account the duration of the exposure event?
Yes, that's a great question. So the question was, in the prescribed burning study, whether we put that up, whether we took into account sort of the interval of smoke that people were being exposed to. And the short answer is we did our best. So what we did was we tried to time, and the Survey Research Center here at OSU was amazing with this, but we tried to time the mail outs so that people would get the postcards right around when the smoke was expected to be starting. So in terms of dealing with duration, we didn't do that. I'm just trying to think if we have anything in our data. We know when people took the study, so we could cross-reference it to see if people who took it in the first week versus the second week had different opinions. I'm not sure if that's quite getting at what you're asking or not.
It's just that's a feature of this, I think.
Yeah. The short time frame makes it very difficult to message to, especially. Mm-hmm. So that was, we were working with some folks doing the public health messaging in Bend, and they they were struggling with the uncertainties of the timing. I don't want to speak too much on their behalf. But tailoring it to the right times was very difficult. And it's really hard to do research on prescribed burning because when we do this kind of survey work, we really want to do this survey work when the event is happening, right? We don't want it to be done months in advance or whatever. We want to know how people are feeling when they're experiencing it. And getting that timing down is so hard when the forest managers, they cannot tell us 2 weeks in advance when they're doing the burn. So it's just a really difficult, that's what part of what made it interesting for me to start studying, but it makes it really difficult to do research on prescribed burning. Yeah.
It is in the back of my mind because exposure, toxicity is a function of dose as well as duration and frequency of exposure.
Yeah.
And at the same time, I would imagine people would tolerate a higher exposure for a very short period of time, and it would then start to desensitize them to the risk as well. So I'm always curious if there's like an inverse association that would eventually tip over and people would just go, it's all of a sudden the risk drops off.
Yeah, that's
perceived risk drops.
So I didn't get in. So in our second study, I didn't get into this in detail, but we did some nonlinear modeling to essentially see if because we were thinking, for example, with PM 2.5 concentrations or smoke waves or whatever it may be, that there may be a plateau where sort of risk and actions go up, and then you hit a certain point and people are just like, whatever, or they're just desensitized, or they don't know what to do. We didn't see that in our data, surprisingly, but I'm not confident that it's not there, if that makes sense. So I think what we have is preliminary, but I'd be really curious because we're going to do some of the similar air quality monitoring stuff in New York, and I'll be really curious at what we see there in comparison to here. Yeah.
Oh, yeah. Last formal question, and I guess if you're stick around, maybe other people trying to questions can stick around for a minute too. So this is from Sarah Rothenberg, and she says, "Thank you. I also participated in the Ben prescribed greenhouse for mercury. For the Ben survey, did you query whether participants have children involved? And if so, did you see differences in responses between those with children and those without?"
That is an excellent response and an excellent question. And my unfortunate answer is we have not analyzed that yet. Oh yeah, sorry. So the question is in the Bend survey in particular, we did ask people whether they had children in the home. And the question is whether we see differences in concerns based on whether they have children in the home or not. My suspicion is that the answer is going to be yes. I am in the process of analyzing that data. So hopefully, and Sarah should be receiving a report on it in the next 2 weeks. So hopefully I'll have more answers there. But yes, a few things we want to do is we want to look at differences with children, people who have children in the home and not. We want to look at elderly individuals in the home versus not, and so on. So we want to do a couple comparisons there. Yeah.
And thank you so much.
Yeah. Yeah, thank you for coming.